Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about essential or non-specific dermatitis. Definition: essential or non-specific dermatitis is an epidermal eruption that may be acute or chronic and localized or generalized. It is a diagnosis that is made by exclusion when an underlying cause such as an allergen or irritant cannot be found, and its distribution is not typical or defined eczematous eruptions such as atopic or seborrheic dermatitis. Here we can see acute essential dermatitis, red weeping vesicles, and in epidermis vesicles and spongiosis, and in dermis perivascular inflammation can be seen. Here we can see also chronic essential dermatitis with hyperpigmented brown lichenified plaque. In epidermis is thickened and hyperkeratosis can be seen, and in dermis perivascular inflammation can be seen. Incidence: essential dermatitis is one of the eruptions most frequently seen by the clinician and is about 11%. History: itching is the chief complaint, prompting patients to seek medical attention. It is often severe enough to interfere with normal daily activities and to interrupt sleep. The itching may be episodic or constant. The patient frequently has a history of sensitive skin that is intolerant to topical preparations such as moisturizers, soaps, and detergents, and to irritating fabrics such as wool. Physical examination: the varied appearance of essential dermatitis occurs because of its evolution from an acute to a chronic process. Acutely, intercellular edema leads to vesiculation. Chronically, lichenification occurs. The polymorphism is manifest by vesicles, juicy papules, patches, and plaques. Secondary changes include oozing, crusting, scaling, and fissuring. Characteristic of essential dermatitis is the indistinct border between normal and abnormal skin. Depending on the morphology and location, various types of dermatitis have been classified. This hydrotic eczema is characterized by deep-seated vesicles which resemble the pearls in tapioca pudding, involving the hands, the palms of hands, soles of feet, and sides of the digits. It occurs bilaterally and symmetrically. Autosensitization or eruption is a generalized subacute dermatitis that follows a localized acute dermatitis, usually of the feet or hands. It is thought to be a hypersensitivity reaction to a substance produced by the acute dermatitis. Xerotic eczema is the result of low humidity and dry skin. It occurs in the winter and is manifest by dry, fissured skin of the trunk and extremities. It particularly affects the elderly and the lower legs of all age groups. Nammular eczema is characterized by oval weeping patches with crusted papillary vesicles. It occurs on the trunk and extremities. Here we can see xerotic or dry skin eczema with a pink scaling, a fissure reticulated patch. This photo is showing a nammular eczema which presents with a dusky pink oval scaling, slightly crusted patches. The conclusion of different types of idiopathic eczema include dyshydrotic, which presents on hands and feet, autosensitization, which is usually generalized, and xerotic, which presents with dry skin, and nammular, which usually present with oval patches. Differential diagnosis. The differential diagnosis of an acute vesicular essential dermatitis includes: first, contact dermatitis, also to be considered infectious processes by a dermatophyte, herpes simplex virus, varicella zoster virus, or bacterium as an impetigo. The appearance of rectangular or linear areas of dermatitis would lead one to suspect contact dermatitis. removal of the top of the vesicle or scales from the edge of the part for potassium hydroxide or KOH examination reveals the typical hyphae or a fungal infection. Scraping the base of the vesicle for a zinc preparation reveals the multinucleated giant cells or herpes virus, which clinically appear as grouped vesicles on an erythematous base. Impetigo can be ruled out by gram staining or culture of the yellow crust, typical of this infectious process. The differential diagnosis of chronic essential dermatitis includes chronic contact dermatitis, psoriasis, drug eruption, fungal infection, dermatitis, herpetiformis, and mycosis fungoides. The history and patch tests differentiate chronic nonspecific dermatitis from contact dermatitis. Clinically, psoriasis is usually easy to distinguish by its sharply demarcated silvery scaling plaques that affect but are not limited to the scalp, elbows, and knees. In any non-specific dermatitis, one should consider drugs as the cause. Discontinuation of medication with subsequent clearing is the only reliable way to rule out a drug eruption. Fungal infections of the skin can mimic dermatitis, especially if lesions are treated with topical steroids. Any scaling patch, particularly if it has an annular inflammatory border, should be scrapped, and the scale of examination for fungal hyphae or KOH preparation. Dermatitis herpetiformis should be considered for any eczematous appearing eruption involving their extensor elbows, knees, and low back. A biopsy for routine and immunofluorescent staining will be diagnostic. Mycosis fungoides can be ruled out by a biopsy too. However, it may take multiple biopsies over time to confirm essential dermatitis versus mycosis fungoides. The conclusion of differential diagnosis of essential dermatitis. Acute essential dermatitis include contact dermatitis, dermatophyte infection, herpes simplex virus, herpes varicella zoster, and impetigo. And for chronic, it's contact dermatitis, psoriasis, drug eruption, dermatophyte, dermatitis herpetiformis, and mycosis fungoides. And we can see dermatitis herpetiformis, which presents with red, slightly scaling and excoriated patch on their elbow of a patient. Biopsy. The histologic hallmark of dermatitis is intercellular edema of the epidermis, leading to widening of intercellular spaces with a sponge-like appearance of the epidermis, also called spongiosis. When the process is acute and severe, it results in intraepidermal vesicle formation. When it is chronic, the epidermis becomes hyperkeratotic and thickened, or so-called acanthotic. The dermis is characterized by a lymphocytic infiltrate. Note, spongiosis is the histologic hallmark of dermatitis. If we can see mild spongiosis with perivascular chronic inflammatory cell infiltrate and mild dermal edema in acute subacute spongiotic dermatitis. This histopathology is showing mild spongiosis and mild hyperkeratosis and mild papillary dermal infiltrate. We can see also spongiosis with parokeratosis, hyperkeratosis, and neutrophilic crust or from secondary excoriation. This histopathology is also showing spongiosis with intraepithelial macrovesicle filled with proteinaceous fluid containing lymphocytes and histocytes. Therapy. Corticosteroids are the cornerstone of dermatitis treatment. They may be applied topically, injected intralesionally, or administered systemically. Steroid creams are used for acute papulovesicular eczema, whereas ointments are better for chronic lichenified dermatitis. However, patients' preference of a cream versus an ointment is more important. Therapy with topical steroids such as hydrocortisone 1%, triamcinolone 0.1%, fluosinonide 0.05%, and clobetasol 0.05% is treatment of choice. Alternatives to topical steroids are the macrolide immunosuppressants, tacrolimus and pimecrolimus. These non-steroidal topicals have the advantage of not causing skin atrophy and when used near the eyes, not causing glaucoma or cataracts. Thick hyperkeratotic plaques that are unresponsive to topical steroids may be injected with intralesional triamcinolone suspension 10 mg per milliliter. This should be done cautiously because skin atrophy may occur. Severe widespread acute or subacute dermatitis is treated most effectively with prednisone, but long-term use must be avoided if possible. In adults, prednisone starting at a dosage of 40 to 60 mg daily and tapered away over 2 to 4 weeks is usually effective. Topical steroids may be added during the tapering period for recurrence of small areas of dermatitis. An alternative to prednisone is triamcinolone suspension at a dose of 40 mg intramuscularly, which has an effect for 3 to 6 weeks. Again, long-term administration should be avoided. Note, avoid the use of long-term systemic steroids because of systemic side effects. The conclusion of therapy for essential dermatitis: initial therapy include topical steroids, creams, ointment, solution, lotion, and foam like hydrocortisone 1%, which is lowest potency steroid, triamcinolone 0.1%, which is a medium potency steroid, fluosinonide 0.05%, which is high potency steroid, and clobetasol 0.05%, which is a super potent steroid. And antihistamines like hydroxyzine, diphenhydramine, and cetirizine, and alternatives include intralesional steroid like triamcinolone suspension 10 mg per milliliter, systemic steroids like prednisone 1 mg per kg or 40 to 60 mg daily in adults, tapered away 2 to 3 weeks. Triamcinolone suspension 40 mg per milliliter, 1 milliliter intramuscularly. Macrolide immunosuppressants like tacrolimus ointment 0.03% and 0.1%, and pimecrolimus cream 1%. Baths and compresses like oatmeal, tar, aluminum acetate, and bleach 1.4 or 1/2 cup of bleach in 1/2 tube of water. Antibiotics if secondary infection is present like dicloxacillin 500 mg BID, erythromycin 500 mg BID, cephalexin 500 mg BID suspension 250 mg per milliliter, 25 to 50 mg per kg daily in divided doses. Trimethoprim, sulfamethoxazole, DSBID suspension 1 milliliter per kg per dose BID, and doxycycline 100 mg BID or polysporin ointment. Antipyretic agents like gabapentin 100 to 300 mg QHS and TID as necessary, and UV light like tanning salon and narrowband UVB. Systemic immunomodulators like dupilumab and tralokinumab, and systemic immunosuppressants like mycophenolate mofetil, azathioprine, cyclosporine, methotrexate, and JAK inhibitors. Pathogenesis: the cause of essential dermatitis is unknown. Scratching results in histamine release, which causes more itching, more dermatitis, and a chronic self-perpetuating eruption. Okay, this was an explanation about essential or non-specific dermatitis. Thank you for your attention.